in like how we are running our data architecture. And I think if you are interested in that, talk to me afterwards. I see someone nodding in the back. Because what I wanted to talk about was the content of what we're doing from a water and sanitation perspective. And we'll go through a little bit of the system, but I'm sure you're going to have many more questions, so feel free to ask here, or we can discuss after the talk. Okay, so we call our data collection system, because you need an acronym, right? So we call it the Mobile Accelerated Data Dissemination System. And so we're using this innovative mobile technology. We are running our surveys at low cost for rapid turnaround, semi-annual indicators. We can expand this to other health sectors. This is another big mission of PMA 2020, is that if you go to our website, there are 2 modules there now, the family planning and the WASH, and we're interested in expanding our modules to do other measures. And the MADS also includes this feedback loop to prompt program improvement. So we're working with the ministries of health in each country and so on. And for me, this is also one of the really exciting things, is that I've never worked on a project where we have the ability to collaborate with country partners and translate a whole way of doing research that they hadn't encountered before and give them the ability to run with this on their own. And so in each country, we have people who are able to collect data, who are able to design studies, and who are able to analyze that data. And we're continuing to build that capacity. So this is only the first year of the project, by the way. That was not clear. Okay. So here's a little schematic describing what our data collection system looks like. In each of our random clusters, we have a bunch of households, and we have a sentinel enumerator. The model for what we're doing is resident enumerators. These are women who live in the communities. They have to be women because we're asking sensitive questions about reproductive health. They live in the communities, and we train them to do the data collection on an Android phone using Open Data Kit. There's your ODK logo. We've customized ODK to meet some of the needs of our project, and I'll go into that. There she is. She's collecting information on her phone, and she's going to send that information to a cloud using the available data networks. So we're finding in most places, we have in Ghana 100 staff, in Ethiopia 250 staff. In most places, this process is able to occur within a few days of data collection. Okay? So even if they don't have a signal right where they are, they can get to a place, a hotspot, where they're able to send forms to the cloud. From there, this is aggregate server. We're putting together information from all of our sentinel enumerators and running data validation and analysis. And we have a whole data validation and analysis team, some of whom are here, who look at things like, how long did it take them to do the survey? What are the GPS coordinates? Do they line up between the household and the female survey? We look for inconsistencies like that. So we're introducing a whole set of quality control through this cloud server technology that we can start to monitor what's happening on the ground. We're also able to do these real-time updates of tables, graphs, maps. And what's really nice actually about our data management team is that they're very organized. And so I'm able to pull data off and analyze the latest data set that maybe came in yesterday and run my analysis. And this is going to be our model going forward. We give our community feedback through our sentinel enumerators, and we're working with our country partners. So there's all these folks who are very interested in the information we're collecting. And after all, we're not collecting it for our own purposes. We're collecting it so that these countries can meet their family planning goals by 2020. Okay. So I'm going to give you an outline of the mWASH study. So within this broader family planning framework, we have set up a set of WASH questions that we think work very well together. And I'm going to go through these 2 bold ones today. But there are several areas that we're investigating. So a big one is on the water service reliability. Another really important one, and this is the one that I've been working on as well, is healthcare facility and household hygiene. And then we're looking at the productive uses of water. So that's like people use water for more than just drinking. Drinking is a really small component of what we use our water for. We use water if we want to grow vegetables. We use water if we want to do washing and so on. So we're looking at all those multiple uses. Sanitation is a big topic, and I actually will show you some sanitation results. We have a section in the female respondent survey on women in water. This is about time to collection. Do you guys know this? So you've probably seen a water talk. How many people have seen a water talk before? Okay, there's quite a few. So one of the widely touted statistics is that women in sub-Saharan Africa spend, and I think the number is like 40 billion working hours a year collecting water. Does that sound right, Sarah? I should have looked it up. It's some large number, but I do know this. The number of hours that they spend is equivalent to the entire productive output of the nation of France. So all of the working hours of all of the working people in France, if you add them up and compare that to how much time women in sub-Saharan Africa spend collecting water, it's the same number. Whatever that number is.
40 billion.
Yeah, it's 40.
40 billion, yeah. I shouldn't doubt myself, but thank you for looking that up. So we have this opportunity. That number is based on very limited information. So we have the opportunity with PMA 2020, we're already planning to go in 10 countries, possibly more, to revise those figures and really underscore the importance of where the world stands with respect to the Millennium Development Goals for water and the future of water services. Okay, so this is what we mean by water reliability. So for one thing, we're really interested in knowing, do the existing indicators capture reliable access to safe water? So you may listen to the rest of this talk and think that I'm going to pick on the DHS. I'm not. I think that they have a very good program. But now, several years down the line, we have an opportunity to look back on what has been collected by way of water and sanitation indicators and do something that's a little bit more progressive. We're taking the next step. So for one thing, is we really are interested in knowing about multiple water sources. The DHS, the Demographic Health Survey, right? Survey. They're done all over the world. I'm sure as public health people, you've seen them ad nauseum. And there are two questions in the DHS about people's use of water. The first question is, what is your main drinking water facility? And then they give you some choices. And the second question is, what is your main water facility for other purposes such as cooking or washing? That's it. But as you'll see from the data we're about to reveal, people are using water for all kinds of reasons, and they're using all kinds of different sources. So that's one thing that we're exploring. Another major thing that we're exploring is how reliable these sources are. So in March of 2012, the UN Secretary General said, we met the Millennium Development Goal for water. We met it. The Millennium Development Goal for water was improving by half the proportion of people who have access to safe water. Safe means it's not going to make you sick. What they collect is information on the hardware. Okay? They just say, what's your main source? They say, well, I have a tap. That's my main source. That's all we know. We don't know if that service is continuous and predictable. Those are really important concepts. And I'm going to argue that we are far off from the Millennium Development Goals. Okay, so let's look at some of these data on water reliability. So just to give you a sense of how important this problem is, here's a figure from the World Bank that they got from another group of cities in Africa. There are 24 cities in Africa. And on the left here, you see the hours that the cities are providing water from their main water utility. This is the big one for the city. So you have Johannesburg running 24 hours a day, much like the city of Baltimore. And it's providing per capita 240 liters per person. But all the way down here, you have the Central African Republic, you have Nigeria, 6 hours per day, the main facility for these major cities, running 6 hours per day and providing only 9 or 7 liters per capita. So in the DHS, those people would count as having access to improved water, which we have interpreted historically as safe. This is a big problem. And this is just one figure from some random cities that is capturing the utility perspective, what's coming out of the plant. They are not capturing the user perspective, and that's what we're able to do with PMA 2020, is to capture the user perspective. Okay. All right, I have to do this. There's two main categories of water. One is improved, the other is unimproved. If you've seen this, you can snooze for a moment, but if you haven't, I just want to explain. Improved water is water that is generally considered to be more safe on average. And so it's based on hardware. These are piped water supplies. The tube wells that you see with the hand pumps Rainwater is generally considered to be improved, and then bottled or sachet water. Unimproved are all these things that probably to someone who's not even an expert in water quality, they would know that, yeah, that does not look safe to drink. So unprotected dug wells, unprotected springs, this is water coming out of the ground, surface water. The tanker truck is an interesting one because tanker trucks look possibly safe. It's a big truck full of water, but we find all the time that they're refilling these tanks with surface water, that they're getting contaminated. In the morning they deliver fresh water from the city supply. In the afternoon they deliver water that they pumped out of a lake. So those are not considered to be improved. And in fact, West Virginia last month, when they had the big spill, was running a lot on tanker truck water. Hopefully they were delivering clean water and not water they found in the street. Okay, so here's some data from Ghana about the number of water sources that people use. So only 32% of households rely on just one water source. This is at the national level. The rest of households are using at least two, and there's a ton of households here, 25%, who are using 3 sources, all the way up to, somebody reported 7 sources. DRC, this is Democratic Republic of Congo, we are not doing the study nationwide for obvious security reasons. Our study is focused on the Kinshasa region. And there you see a similar trend. It's a little bit more skewed towards one water source. And when I get a chance to look at the demographics and we can break this down by urban, rural, I think that might explain a lot of the difference between these two countries. But even in the Kinshasa region, in the DRC, more than half of people are using more than one water source. So we're not capturing that with our existing Millennium Development Goals and indicators. Okay, so what we've done is look at all of the sources that people use. Okay? Here on the bottom, you see those categories I just showed you a couple of slides ago. And on the left, these 3 colors have to do with improved water sources. And on the right, these colors have to do with unimproved water sources. So this is, like surface water, things like that. And I want to point out a couple of small vignettes. So first I have to explain this graph. The black colors here are what was measured in the 2008 DHS for improved water sources, just like the gray here on the right. In 2013, we did our PMA 2020 mAD study, and we measured 2 things. So one was, we asked somebody, what are all of the regular water sources that you use? So anything that they rely on for more than the occasional use is considered to be a regular water source. And we're finding from this graph that households are reporting a lot of things. And what are they? Well, it turns out that they're distributed across the spectrum. And we wanted to compare that regular source to the main source, which is what we already have been capturing for years with studies like the DHS. Okay, so let's look at some of the stories here. So first of all, I'm going to show you what's happening with the all unimproved sources. So this is anyone who is relying on an unimproved source. In 2008, they reported that 15% of households, 15% of the population is relying on an unimproved main source. And we found a very similar number with our study in 2013. So we haven't seen much progress there. But if you look at who relies on unimproved sources, even if it's not their main source, they're drinking it. Remember, this is for drinking. It's not just for any purpose. That number shoots way up to go from 15 to nearly 20. So it's almost a 1/3 increase. Okay? Another little vignette is that there's this massive use of sachet water, and this is a fun one. So if you look at the main drinking water source, very few people say that they're drinking sachet water. But when we look at these data here, we see a huge number of people that are drinking it regularly. And this has been growing. Even this blue, comparing the blue to the black, you see that there's a large number of households in West Africa, in Ghana in particular, that are relying on sachet water and bottled water, mostly sachet, as their main drinking water source, and an even larger number that are relying on it as a regular source. And these sources are highly suspect. So there's been all kinds of studies which show that the sachets are above guidelines. There's absolutely no regulation of this. Here's one, is a brand that's called Trust Me. This is actually the second brand of Trust Me sachets. This one popped up in 2012. It was put in place by a Western NGO. And when we were there in about 2009, we analyzed a different Trust Me brand, and we found that they had E. coli in some of their bags. Because anybody with a machine and a water source can bag water and sell it. So we're seeing this explosion of what is considered to be improved water, the sachet, that's counting towards meeting these Millennium Development Goals in places like Ghana. It's not as popular as looking at preliminary data in our other study countries. So it's very much a market-driven, country-specific event. Rainwater is also very, very commonly reported as a regular source. Few households consider rainwater to be their main source. We go back here. But many, many households consider it to be a regular source. And I'll have more on that in a moment. Comparing the DRC, we see a very similar trend that when you consider regular sources, there's a lot of households who are using rainwater, very, very few who report this as their main source. And the same thing with bottled and sachet, although it is not quite as popular. Okay. All right, so I thought I had something more on rainwater, but I don't. So these new mWASH indicators talked about multiple water sources, and we talked also about the reliability of these sources, and that's what I'm going to show you right now. There's two ways in which water sources can be unreliable. So one is that it is only seasonally available, and the other is that on any given day, it may or may not be working like you expect it to be. So I'm going to show you two examples in the next slides. Okay. In the portion of the year that rainwater is available, only a very small number of households report that they always have access to rainwater. These folks could be storing the water on site in big cisterns. We haven't been collecting those data. We don't know. But half of the population is saying it's available for some part that's more than 50% of the year. The other half of the population is reporting that it's only available for a small part of the year, that's less than 50% of the year. Okay? Similarly, you have a seasonal variability of rainwater. We have daily variabilities of piped water. And this is the big story. This is where I'm really excited for where the mWASH study can go. That a third of all piped water is unpredictably intermittent. This is what we found in Ghana. That about a third of households, these are three different types of piped water, dwelling, yard, and public. A third of households cannot rely on these sources at all. They have no idea when it's going to be running on any given day, and it is often not running because it is unpredictably intermittent. In these households, a third, they know it's going to be off a certain time. Maybe it's always on from 1 p.m. to 5 p.m. or something like that, and they can plan for that. And then there's about a third of households who are saying that it is always available, that I can always access the water when I want to. And that's just for piped water. Bore wells, they go out for months at a time. And to get the user perspective on systems like that is incredibly important. Because if you're about to set policy for a water intervention, and you say, well, I'm going to set my targets of 10,000 new bore wells by the end of this project, and you don't consider this perspective, that these systems are frequently breaking, you're going to repeat the same errors of the past. And that's what we've been seeing in the water sector for the past 50 years. And so PMA 2020, we're positioned to get the user perspective on all of these water sources, on all these different types of interventions. Okay. So sanitation, I'll show you just a little piece of that. The DHS, just, again, it sounds like I'm picking on them, right? The DHS captures the main sanitation facility. We ask about all sanitation facilities that households might be using. And we have this special question on open defecation that I'm going to show you some data from. This is the only one I'll show you data from, because these two are more or less standard questions. Okay, let's look at this. If you ask someone, what is the main sanitation facility that you use? You get it maybe in Ghana, I think it is a 23% of households say that they don't have a facility, they practice open defecation. 23%. But if you ask them, does anyone in your house regularly practice open defecation? We're getting a very different answer. And because that could be, well, you know, it's not me, I use the bathroom, but they don't. They don't do that. So there's a little bit of shame factor in some of these questions. And what we found is that almost 40% of the population live in a household where at least one member of the household is practicing open defecation. So this problem is far more widespread than traditional indicators are acknowledging. That households are complex things, and if you just ask what's the main facility for your household, you're going to get a very different response from 23% up to 40% of when you consider who's regularly doing it, who lives in my household. You have a question?
No, I mean, it's just astonishing the big data gap in terms of...
Yeah.
I mean, don't feel bad to bash DHS. I think we all recognize the limitation.
That's right. And we could even bash them more if we, somebody suggested this to me. If we take this no response, don't know group and we put them over here, then we could say it's more than, it's almost 50% of how people, because it's very likely that these no response, don't know people, they know. Very likely. Okay. All right. So another big focus area for us. Go ahead.
I'm wondering how. So, I mean, I wondered how you compare DHS data to what you're collecting. Since DHS is supposed to be the nationally representative samples, whereas I think you're saying yours is like our convenience.
But you spent about 3 minutes describing how the setup of the survey.
Yeah.
I mean, you jumped right into the...
Yeah, so I don't know if I can fill 3 minutes, but I think I can answer your question, that this is a nationally representative data set. And so we worked with the statistics office in each country to draw random clusters, and then within those clusters to do a household listing, and from that listing to draw random households. Okay? Good question. All right, so the other main area that I'm going to present today is all about hygiene. So we looked at household hygiene and clinic hygiene. And so these are some somewhat standard indicators about soap, water, and proximity to sanitation facilities in the household. This last one is new. And then the clinic hygiene is totally new. I have never seen studies at the national level like we are doing about the level of hand hygiene in healthcare facilities. So these are the things that we're able to collect. We're able to collect the staff to facility ratio, so we know, how large each facility is in terms of staff. We can record the prevalence of soap, running water, and stored water at hand washing facilities that are available for the staff. So nurses interact with dozens and dozens of patients every day. They are a major driver of household infections. Outbreaks of infection in healthcare facilities, and similarly with doctors and other healthcare workers. So we're able to really tease some of these variables apart and then ask the question of where are our gaps in terms of hand hygiene. And so we could say that, well, these rural outposts, they really have terrible hygiene. The big city hospitals are doing okay, but the rural ones are not doing okay, and we can measure that. So I wasn't able to get to that level of analysis for today's presentation. This is an ongoing, rolling process, but I can give you some teasers for that. And the clinic hygiene, lastly, we could look to see whether communities that have clinics with good hand hygiene also have good household hygiene. So there's a lot of information we can explore. And so the other piece of this sample frame that I probably should explain to you is that, yes, we did random clusters, we did household listings, and we chose random households. We also have mapped all of the service delivery points within each cluster and randomly selected 3 private facilities for interview. And we've also selected 3 public facilities for interview. And the facility that services our cluster does not necessarily need to be within the geographic boundaries of the cluster. So if you live near a big hospital, it's a big public facility, and you're within their catchment area, then we are interviewing at that hospital. Are you with me? Does that make sense?
I have a question around water reliability.
Yeah.
Water reliability, you talked about whether something was a regular source and whether something was a main source. And then if you sort of like look at something like rainwater, It's not like seasonal variability. Then how is that a regular source when people don't even have access to it?
Right.
So if you could like clarify the definition of the regular.
How do we ask the question?
Yeah.
I don't think I have it written down in the presentation, but what we ask is this. We say, please tell me all of the water sources that you use on a regular basis for any part of the year. Select all that apply. Okay, so this is just underscoring the importance of clinic hand hygiene. You can stop the spread of infection with good hand hygiene. You increase patient confidence. There are studies that show that patients, when they see that there's good hand hygiene in their healthcare facility, they're more confident in the healthcare. And in sub-Saharan Africa, there have been studies that show that hand hygiene correlates well with drinking water treatment at the site. A lot of these service delivery points do not have clean water coming into the facility. And so they have to do treatment on storage on site. And so there's a correlation between facilities that practice good hand hygiene and that also practice good water practices. And so this was a study done in Geneva showing the compliance with hand hygiene. And I'm putting this up here just to show you that what we've done is we've done direct observations of water and soap in all these facilities. But what we haven't done is figure out whether people are using these facilities when they are supposed to. And so this is in Geneva in like the 90s, okay? In a hospital in Switzerland. 50% of nurses were, well, less than 50%, this is a study of nurses, were following protocols for hand washing at this facility. Then they did an intervention of, when should you wash your hands and remind all the staff. And you saw that number for hand disinfection and hand washing started to change. There's a lot more use of those disinfection things. But we're still only at 70% compliance in these, what I presume are very expensive hospitals. So we have a long way to go in places like Africa where we're doing our study. So for the household hygiene, remember I'm going to show both household and clinic at the same time. The percent of households who report that they have a place to wash their hands in Ghana is only 12.4. 12.4% of households have a place to wash their hands. These are households that prepare food for their families. They maybe practice open defecation. This is a major problem for public health. Okay? And when we go and look at those facilities, what we find, this is the overall percentage of the population. 10.5% of people allowed us to observe the facility. 7.3% of people have water with soap. That's the overall percent of the population. So it's 7.3% of the total. It looks like it would be about 75% of facilities that we observed. Are you with me? Yeah. I've presented this both ways, and every time people get confused, so I'm presenting it this way this time. Water without soap. There's a number of people where we looked at their facilities, and they had water, but they did not have soap. That's 1.6%. And there's percentage of households that had soap but no water. And then of these folks that we observed, some of them would show us their facility that had no water and no soap that day. Only 4.4% of people have their hand washing station located near a sanitation facility. And 3.4% of people have a facility that has what you would expect, water and soap, that's near a sanitation facility. Any questions about this?
What's the significance of being near a sanitation facility?
So we leave near subjectively up to our data collectors, so we don't have a very firm definition of that. But it's sort of like, here, you use the facilities and you wash your hands when you're done because it's right there.
Oh, I
it's
see.
not, in some other room or something like that.
Near the toilet, right, okay.
Yeah. Yeah, because a lot of them are not toilets, they're pit latrines with slabs or, yeah. Okay, so for DRC, go ahead.
Sorry, remind me again how frequently the data was collected, or just a single time point?
This is one time point from late 2013, so it was sometime October, November, and we're starting round 2 data collection in a few weeks. Actually, it's already underway now. It's underway now. Yeah.
So you're getting seasonal variability, right? Because the intermittence is sometimes linked to seasonal
That's right.
pressures as well as the intermittent itself fluctuates from season to season.
That's right.
So that is that being captured as part of this strategy? Or?
So we do ask some questions about the amount of time they spend collecting water. We ask the questions about water service reliability and so on. So we're getting that
But
variation.
the sampling frame precisely is at different time points of the year, so that as you compile the overall data set,
Yeah.
you know what things are like in the dry season
Right.
versus the monsoon or tropical season.
We haven't intentionally aligned the timing with the seasons. It is every 6 months. I think in West Africa we're probably going to hit the dry and the wet season, but I'm not totally confident. I don't know. Are we going to hit the dry and the wet season with our 2 points? I'm not
It's
sure.
6 months apart in each country. It may not be aligned in all cases.
Yeah.
We do ask the question of water collection on the dry versus wet season.
That's right.
Remember, this is leveraging access to modern contraception in a series of questions that is a partnership with the main driver being an entirely different scenario. And we're really excited about that opportunity, but it's not like this whole multi-million-dollar study is on what people do up at night. Water and sanitation is what keeps those guys up at night.
So we'll show you some results from the DRC. There we have a population reporting a place to wash hands that's higher than Ghana, but this is again just the Kinshasa region. And when you look at, so this is a different denominator, of these 18%, 82% had soap. Almost 70% had stored water, 35% had running water, 11% had their hand washing near a sanitation facility. So we see largely a similar trend in both places. These are big gaps in household hygiene. Okay, so the clinic hygiene, this one's brand new, just analyzed freshly. For 140 facilities in Ghana, we threw out a couple of outliers. These are the 7 different types of facilities that we collected data from. So we have these big hospitals, we have health centers and health clinics, these are community health posts, pharmacies and chemist shops, and others. So this sort of represents a sliding scale of size and mission, the type of staff that they have, and where they're located. And then these 2, we don't ask any of the hygiene questions at pharmacies or chemists and drug shops. Okay. So this is cool. So the nurses at the facility, this is from Ghana. Most facilities have fewer than 50 nurses. A few facilities are very large. Same thing with doctors. Most facilities have under 10 doctors. And we actually end up, because the doctor staffing is so small, with a very high ratio of stations per doctor, an average of hovering around 4 hand washing stations per doctor. But we have a much lower stations per nurse. So an average of under 1 station per nurse. And you can imagine, especially in these larger facilities, that they have lots of rooms to go to. They're interacting with lots of patients. This is not adequate for preventing the spread of disease. And I would love to dive in more on this as well. So we have a lot of information that we have yet to analyze here. So when you look at those facilities, so we say, how many facilities do you have to the managing authority? And they count. They're tending to give very precise answers, which sort of surprised me, like 37. We have 37 hand washing facilities. We go look at one of them and determine whether there's soap, whether there's stored water, running water, whether they have soap and water, and whether they're located near a sanitation facility. And so we have very high rates of having some form of soap and water, 95%. And this one I actually realize is perhaps not very meaningful. So in the case of the household, it should be near a sanitation facility, but in the way that we're collecting data at the SDP, we could be looking at an exam room, and in which case it wouldn't be near a sanitation facility. So it's not necessarily a negative thing. So that was surprising to me when I saw how high the prevalence of soap and water were at these facilities. In fact, I was in Ethiopia, but we were visiting one and it didn't have soap and water at the healthcare facility. So I got excited for the study. I'm like, look at this big gap we're going to identify. But as it turns out in Ghana, most of these facilities have soap and water. The question is whether they're using them. So for hygiene, here are some of the bullet points, the takeaways. So we're making these direct observations of the condition of the household and hand washing sanitation facilities. Few people live in households that have a place to wash hands. Even fewer have water and soap there. And even fewer, it was only 4% in Ghana, have hand washing facilities near sanitation facilities. The clinics have widely available hand washing station, but a lower nurse to hand washing station ratio. Okay. And so the WASH summary overall, this is looking more at the water reliability, is that multiple drinking water sources are very common. These traditional indicators are underreporting them. The water sources availability varies seasonally, and it's often unreliable. Remember, 2/3 of households in Ghana who had piped water had intermittent piped water. Sanitation, open defecation is widespread, and these traditional indicators are underreporting that. For hygiene, few people belong to households that report having a place to wash hands. We just went over those. And few people belong to households that have soap and water near a sanitation facility. So I'm going to thank our staff on the ground. A lot of this came from Ghana. Here's one of our training sessions. These are enumerators who collected all the data. Notice the matching shirts. We have swag at PMA 2020. And there's a lot of people to acknowledge, which I won't acknowledge them individually, but just the groups. The foundation, of course, is supporting the project. The original mobile data collection came from the Osprey Foundation, the one that we did that we're able to design the data collection system here. These are probably not even a complete list of all the folks here in Baltimore who are working on this project from the Gates Institute. We have our partners in Ghana, the Tulane. This guy, Phil, put together all those DRC graphs for us, and our partners in each of the countries, and my colleagues in the Water Institute. So I'm going to leave you with food for thought. Oh, it's time for food for thought. Go ahead. You have a question on the acknowledgements?
Yeah, I just have a question on this question, food for thought for you, probably. Question on sanitation around the main sanitation facility and the one, like, does anyone in your household regularly defecate outside, defecate in the open? Well, was this question at the household level, or was the main, or was one at the individual level and the other at the household?
They were both at the household level. And sometimes the household interviews are being answered by several people who live in the household. We get one person who gives consent, but the household interviews could have several respondents.
Yeah, because this is a complex behavioral change problem. Even the people who have toilets or some form of sanitation at home not necessarily go. So.
Yeah, so they may not be telling. So the fact that 40% of households are telling, and then there's this whole group of people who are not telling, let's think about that. All right, so here's some more food for thought. Water scarcity. I often get this question, you know, what's the link between family planning and water? Why are you guys working together? And, you know, there's the obvious choice of like, well, we help design a data collection system. We're doing both studies in parallel. But this is a big deal. This thing right here shows you mega cities. These are cities, well, they're not all mega. Cities over 5 million people across the world and their water scarcity problems that they're going to have to deal with. By 2050, you're going to have hundreds of these cities coming on with seasonal or perennial water shortages. That's the link right there. And this is the forward thinking that we need to be doing here at the School of Public Health with PMA 2020, is how do we address this problem so that these cities, look at, you can't even see India, there's so many of these big cities that have water shortages can meet their needs. So I'll leave you with that.
Two questions, and thank you for this. One, this is a fascinating data set. To what extent is any of it going to be public?
It's all going to be public. It's just a question of when.
At what granularity space?
I mean, there's an IRB issue, so we have to de-identify the households and so on. And you know, we are publishing summary reports that are sort of on the, you know, the 2-pager level. But those are already public. But the data set itself will be made available. Is that right?
Yeah, we don't have we're still working on the policy around that, but probably within a year's time.
Yeah.
What I expect.
That's right. I should show that sled running downhill to answer the question. Scott has a nice cartoon of how this project is just running downhill at full speed. And so we're already collecting round 2 in Ghana. We haven't made our data set public. It's just all happening at this incredible pace.
So second question, and mindful of the fact that this is put on to another main focus of the grant. While you're observing water facilities, would it be possible to do some sort of water quality assessment?
Spend some money, for sure. Or if they could take a picture, dipstick in a picture or something really simple, which I know we talked about that before, but yeah.
Can I ask you to maybe expand a little bit on some of the logistic challenges that you faced in taking a mobile data collection platform to this level of scale?
Yeah.
And thinking about not just the actual training and
right.
handset management and sort of maintaining sort of this large workforce of tools,
right.
But then also if you could just talk about the data streams on the back end.
Yeah.
And you mentioned, every few days data can go up to the cloud where it's aggregated and whatnot. But even have you experienced regional issues with data sharing or data export from a country level to a cloud server, which is something we're encountering in some African sites where they want local residents of data and then export. So just
there's a lot of questions there. So in Uganda, to answer your last one, they insisted on having a local server that's physically hosted in country, and it costs like 5 times as much as running it through Google, which is what we've been doing. And it's potentially less secure and potentially less stable down the road. But it was a requirement for approval from the Ministry of Health, and so we dealt with that. And I think we had a similar thing in DRC where they wanted a local server, but we convinced them to use Google, if that's correct. Yeah. And I think, so we're handling those kinds of things on a country-by-country basis. As far as I think that, my main role in running forward with this project is to design the data collection process. So I've been working a lot on the forms. The forms are coded in Open Data Kit. There's all this logic to that. So you guys have probably seen some of that before here. Skip patterns and so on. And we have very sophisticated skip patterns and constraints and data quality checks, warning messages, and all of that. So that coding has been challenging because one small change has major consequences across the different forms. And then what we've been finding is that each country wants to put a little bit of a spin on our survey. So there are obvious things like the school categories are different in different countries. And then there are some where we say, well, we want to ask a question this way, and we discuss it with the team, and they say, no, we can't do it that way, and eventually we have to change the survey. So tracking the different form versions is our most pressing challenge right now for data collection. That we have right now 4 surveys. We have the listing, the household, the female, and the service delivery point. And that's going on in currently 3 countries, soon to be 4, and they're all a little bit different. So we've been exploring management systems like GitHub, if you guys are familiar with that, for managing these forms, but they're not designed for, the coding is all done in XLS sheets, which are binaries, they're not text files. So we don't have an ideal solution right now for that.
And the back-end data aggregation is through some sort of...
I'm looking at our data manager over there.
There are a lot of unanticipated problems that we ran into, but so far we've been able to cobble together our solutions. One thing that we did not anticipate is originally we thought we would just be able to directly export data from the server onto Google spreadsheets and be able to run with it. Turns out that Google has a 400,000 cell limit. That seems like a reasonable limit, but we very quickly ran out. So we now use a different program that's also developed by ODK. So we have to actually directly download the data onto a computer and export it onto a CSV file, which does work, but it's not ideal. It's great if you could be anywhere in the world and just export the data into a CSV file and have it. And instead, you do have to be in sort of a set computer, because it does take a very long time. And they're huge data sets. Once you have 10 countries and multiple rounds, it would be impossible to have it all on one computer. So that's kind of been sort of the logistical challenge. We've also found that we're doing this in places that don't have great mobile technology. So a lot of the times, the resident enumerators might just be like send, waiting for it to send. So we'll end up with 5 copies of the same form. Usually it's very easy to just
figure that out and drop it. But a bigger challenge is that Luke didn't actually talk about how we adapted the app, but we have a linking function between the household form and the female form so that you can link between the forms and it's very easy. But unfortunately, you have to send them differently. So sometimes they'll send one form and send the other, and we don't always link perfectly. Again, things that we can clean up over here, but it does have a little bit more of a data management aspect to it than what we had originally intended. Those are kind of the big ones that we've really run into. I don't know if there's...
Yeah.
So
By the way, this is Linnea Zimmerman. She's a PhD student who is our most excellent data manager.
Thank you.
Yeah, so you said that along with sachet water, rainwater is often contaminated. Is that because of the container it's in? Or is rainwater not clean?
It could be both. It could be the container. There's a lot of people who are dipping their hands in these containers depending on how they're designed. Also, they're the first flush diverters, so when the rainfall starts to come off the roof, it fills up a little bucket and then it kind of comes down. There's different designs. And so that first wash is dirty and that's diverted away from the storage, but those things break often. So
the rainwater itself is drinkable, right?
Yeah, yes.
Okay, that's what I was
But first flush is a major issue
Okay.
because whatever you store in your cistern can be instantly contaminated because of birds and animals and all sorts of things. And in the seasonality, that first flush is incredibly important if you haven't had rain for 2 months.
I see.
So
Oh,
converters
right.
are
Yeah.
not integrated in many systems.
I see.
And thatch, you can't collect rain off thatch, which is basically anything
Right.
that's leaking because it just turns it turbid and it's not of high quality compared to tin and other types of roofing. So rainwater is good, but storage
I
is more
see.
important by far. But first flush is also a very important thing, especially if you go to scale and you want to store it for
Yeah,
weeks
I
to
see what
months.
you mean. Okay, thanks. Yeah.
Okay, so you were asking about sanitizing and you're asking with water sanitation. This is sort of personal topic. How do you, or are you planning to look into how people answer, like, people who answer don't know how they responded to like questions from the family planning, like some sort of bias in their...
like a link between their contraception behavior and their water behavior? Yeah, we would. but I think it's too early for that right now. So one of the areas of overlap that we're exploring is the menstrual hygiene section. And so we have some new questions for round 2 of data collection in all the country on menstrual hygiene. And you know, there's links between the sanitation facility and your ability to practice menstrual hygiene and between your contraception choice and menstrual hygiene. So we could explore that further, but it's very, very early for something like that.
Yeah. Do you ask on the user survey, do you ask about religious affiliation?
No.
I was saying about some of the cleanliness requirements for Muslims. That's something that may show up if that was an indicator.
I think well, most studies show on hygiene things. I'm not sure about water or sanitation, but hygiene practices is that religion is not a major factor in the level of cleanliness of their hands.
So I missed what you asked. I'm sorry. What's it about? Well,
Just religious affiliation, but that was a question on the user survey.
No, but actually use of water for religious purposes can be high. We found that in Ghana in certain subpopulations. Where more volume went into cleansing feet and hands during practices than it would be for other practices. So, which is part of that. It's part of the study, but not.
We're doing some work on and facial cleanliness as a factor, and we're finding that there wasn't a lot of that in northern Kenya. And one of the suggestions was because it was a high Muslim community, cleanliness was the reason. So, one quick question about the handsets: is offline data collection as well?
Offline data collection?
Yeah, without connectivity, you're able to collect data.
Oh yeah. So the interviews take place. In fact, we make them go offline so that while they're collecting data, they don't lose their battery on their phone. And so the entire interview might take between 20 minutes and an hour. It really depends, I think, on the size of the household or whatever. And then at the end, you can send through the data network.
Or save it if you don't have connectivity. Do the next household.
Yeah. Yeah, and the linking that Linnea alluded to a few minutes ago, when we do the household roster, this is the custom part of ODK for our project, you learn about everyone that lives in the household. And so any woman who is between ages of 15 and 49 is eligible to be interviewed for the female respondent questionnaire, which is about her family planning and birth history and things like that. And when you save the household roster, we are automatically generating forms for each eligible woman within the household, and that is one data package that the entire household has to be completed and sent at one time, and changes in one form affects the other forms and so on. So they're all linked across. So.
I have 2 questions. In the ODK form, I was wondering if you're using any of the media that the phones might have, in particular for the direct observation, whether it's pictures or photographs and or videos. And then secondly, I was wondering, since this is kind of the mHealth project, I'm wondering if you're collecting any metrics from the user end as to how they're using mobile technology for family planning or for accessing water or
That's a cool idea. We aren't doing that. We are taking pictures. We take pictures of the household entries, mainly as a way to identify to make sure you're at the right household. So when we do the listing and it's selected, we have a photo of that. And then if you do the roster and one of the women that you were supposed to interview is not present, then they can come back and verify that they're at the right household. But taking a lot of pictures would be problematic for data transmission and even storage on the phone. And we have several backup systems, so we're backing up all of our data locally from the SD card on the phone to the internal memory. And that was one of our, oh, by the way, as Kellogg would say, that we were finding a lot of the SD cards were getting corrupted, and we got unlucky that a couple of the enumerators who had done a lot of data collection hadn't sent their forms to the server, then their SD cards got corrupted. So we had to redo those interviews. So we're backing it up locally onto the phone, internal memory, and we're backing it up on Google Drive automatically.
I think there's a huge value to these technical lessons learned.
Yeah.
That we've done a few fail fairs with USAID and other partners.
Yeah.
But I think the scale at which you guys are doing this just stands to contribute so much in terms of just the technical operations of implementing, scaling, and sustaining large-scale data collection systems on mobile. That I hope we have armies of students who would love to work with you guys to document that.
Wow! We have.
If you guys are looking for capstones,
Yeah. And we have all kinds of problems that need solving. So no time
documenting and solving. I think documenting and writing about is a major issue.
Yeah.
Can I ask one more question about the ODK mechanism that you guys chose to be your sort of primary interface? Tends to be a unidirectional system where data gets pushed from the data collector to a server.
Yeah.
But do you have functions where you actually pull data down from a server in terms of like updating, longitudinal follow-up, or is there any sort of
with the respondent
with your mobile system? Is data bidirectional or is it just unidirectional? I guess it's a question. Or maybe
it's primarily unidirectional. The long-term plan, and within this year, we're going to build that bidirectional capability for dissemination. And it's sort of questionable for us what is the correct point of dissemination. So we have nationally representative data, and if we respond back at the individual level, what do we show them? Yeah, and then but just having text, email, and phone capabilities all in one device with our staff has enabled a lot of communication that's a little less formal. So Linnea runs every week a supervisor check report in Stata where we identify any problems, we know how many forms are uploaded, how many are pending, and then our supervisor staff can communicate directly with the field staff about their performance.
Good. Well, just to say that this wasn't designed to be a panel study, so we aren't doing longitudinal. Each round is a newly collected sample in the same enumeration area. And the place where we might have some longitudinal ability is in this service delivery point, especially the public sector, because we'll be re-interviewing the same facilities over time. So there will be that opportunity, I think.
The biggest question we get from anyone when we talk about mobile data collection is, how do you prevent valid but incorrect data? And my response is always, we've had that problem from the days of paper, where any one of these responses could be valid, and so none of our range checks or consistency checks would capture them if they're plausible, but yet they're incorrect. So the quality control mechanisms remain an issue whether we're doing paper or digital.
I was just saying, in some ways, I think that I don't want to say that we scare tactics so much, but when we do our trainings, we have them do a survey, and it sends it to the cloud, and we pull it down, and within 10 or 15 minutes, we're like, these are the results of your survey. So if somebody put in that they're 75 years old, we'll be like, hey, why don't you stand up so we can see you're 75 or 250 or something like that. Right. Or we do the GPS points, and we say we know exactly where you did your GPS points, and we do kind of instill in our enumerators and our supervisors from the beginning, we are watching you.
Yeah. We
do
also want to implement, and I want to implement, the integrity check that they certify at the end of the form, that they've done an honest job completing the form and they sign it. But I wanted them to actually take a selfie, because there are studies that show that the eyes help you conform more to rules, so that you're not breaking the rules. But anyways, yes.
Awesome. Well,
that was
thanks so
vetoed,
much.
the selfie. Yeah.